Good morning and good afternoon, and thank you for joining the first Q&A session of today. This session will be on the international aspects of cholangiocarcinoma, and Helen and myself are delighted to be joined by Dr. Narong, Dr. Shiji Kai, Dr. Vincenzo Cardinali, Dr. Jesus Benialis, and Dr. Joris Erdemann. Over the next 20 minutes, we'll be fielding your questions to this panel. And I'd like to start by handing over to Helen, who has several questions to start the session.
Thank you very much, Gary. Well, firstly, I'd just like to welcome everybody to this panel discussion. Thank you so much for your presentations and for your time today. It's truly appreciated. I'd like to turn to Professor Narong for the first question. Yes, you're up first, Professor Narong. Thank you very much for your presentation. As always, your dedication shines through everything that you do, and it truly is impressive to see what is happening now in Thailand and in the other countries in Southeast Asia. So I'm going to ask you something slightly different, I think, that is something that interests me greatly. We understand that the major cause of the high incidence of cholangiocarcinoma in Thailand and in other countries all along the Mekong River is liver fluke. But this tends to be in the rural areas where raw river fish is eaten. So what is the situation in the towns and the cities? Are you seeing cholangiocarcinoma occurring sporadically, the sporadic type of cholangiocarcinoma, as well as the liver fluke-induced cholangiocarcinomas?
Please ask again, Helen. What is the last question? What is the last sentence?
Are you see here in the West, a lot of cholangiocarcinoma that we see is sporadic. There is no known cause. I'm wondering, are you seeing that in the towns and the cities?
Sorry, I cannot get your question. Yeah, it's in the European country, the cholangiocarcinoma is sporadic. In Thailand and in a nearby country here, it's a form liver fluke. And so what is your question?
Do you see sporadic cholangiocarcinoma in, say, Bangkok?
Oh, okay. Yes, thank you.
We get there.
Okay, thank you. I get your question. In our study in Thailand, the risk factor of cholangiocarcinoma is around 70.
I think we may have lost Narong.
I think we may have lost Narong.
Shall we move on?
Yes. So, a question that came in earlier today during Shiji's presentation. So I'd like to go to you, Shiji, with a question. And the question is, are there currently any measures in place in China to increase public and healthcare professionals' awareness of cholangiocarcinoma? I think we have Shiji's muted. Are we able to unmute Shiji's microphone?
Oh, okay. I'm sorry.
There we go.
Can you hear me? Okay. this is very important questions, and I think according to my sort of experience and personal communications with my colleague and the collaborators in China, so the public education is doing better and better. Simply, where you turn up the clinic, you can see the blackboard in the department, or to tell you, for example, what is cholangiocarcinoma and what is the symptoms of it, and the treatment would be how difficult to treat it, and what is available for treatments for mostly routinely used for the clinical treatments, and the outcomes of the treatments as such. So clearly they are doing better and better. So however, it depends on the regions. The coastal cities along in China, where the economic are doing better, then patients always get better looked after. Whereas where remote areas or the less developed regions, is slightly a drawback. So you can tell from the map, it divided into that kind of the geographic regions is widely distributed. Again, about the data available according to publications, a bit more, I mean, the dots you can see from the map, a bit more density in the somewhere the southeast and the central regions of China. So, yeah, and so it's varies between the regions, geographic regions of China. But they are, I think, personally, I got the impression it's doing better and better in terms of the public education awareness of it. However, the cholangiocarcinoma is less, was paid less attention on, while it is rare and malignant. So still we need a lot of work need to be done.
Can I pop in with a supplementary to Shiji?
Yeah.
Is that okay? Shiji, looking at the information you've shared with us, which certainly for me and no doubt for many people is very new to us. We hadn't realized the numbers involved in China. We know China has a huge population, but the incidence of cholangiocarcinoma looked huge. What sort of percentage would you say is involved? Is it similar to the West, or is it higher than the West?
Yeah, it's a very important question. So overall, we don't have I think a complete data to tell you. But according to sort of a couple of publications in Shanghai, where the central economic booming cities, and they do more work on sort of different type of diseases, including cholangiocarcinoma. It looked like falling between 15 to 20%, so varies, of 15% of liver cancer.
Okay.
Yeah.
Interesting. So we need to keep an eye on what is happening in China, I think.
Yeah, I think I'm trying to talk to someone who possibly could do some analysis using the National Central Cancer Registry database to find out exactly the incidence and mortality of the cholangiocarcinoma in China.
Well, that would be of great interest. So do let us know.
We could bring our experience to collaborate with them, and where we had already. So we could initiate that kind of collaboration to start with.
Thank you. Thank you. Back to you, Gary.
Excellent. I'd like to just put a question to Dr. Erdemann. So we saw from Hein-Josef Klinken's presentation that there's some incredible work happening in the Netherlands at the moment, and quite remarkable in terms of the advances that are currently being made. So quite a general question, but in terms of what are the main ways in which other countries could learn from your examples to build interest and activity in cholangiocarcinoma?
Well, thank you for that question. I think what makes the Netherlands unique is that we have a very simple healthcare system. We only have government-funded hospitals, similar to the UK. We don't have private. So there's no financial incentive in the Netherlands for doctors, which makes collaboration really easy. And I think we've shown in previous projects like the pancreatitis working group or the pancreatic cancer working group, which had led to tens of publications in high impact manuscripts, really practice-changing papers on like the PANTHER trial, which has revolutionized treatment of pancreatitis, or big randomized trials. We're able to do this because we work together. And I think the thing the world can learn from the Dutch is not what we find in our results, but how we do it. Because I think collaboration is the only way forward. And to collaborate, first you have to take down the egos, you have to take the financial barriers, but maybe the egos is more important, and work on this together. And the thing is that if you start to collaborate, the pie gets bigger. So you're not going to eat a small pie by yourself, but you're getting a much larger chunk of a really big pie. And that's how collaborating works. You get more by collaborating than by working alone. So that's, I think, the main message. Another thing we're really trying to move on is shared decision making in cancer care. Since, well, you've seen the developments in this field and in many other fields of cancer treatment. The choices and the options are so various, and for a patient it can be very difficult to choose. Well, for instance, if you have a perihilar cholangiocarcinoma, to choose for an operation is a big decision, because mortality of these kinds of resections is huge. So you really have to think about, is this something for me? Is this something that fits in my ambitions in my life? So if someone is 40 years old, well, then an operation is a no-brainer. I'll go for 2% chance of survival and take 100% or 99% risk of the operation. But if you get older, your perspective in the world changes and other things are more important. So, and I think the AMMF is an organization that's really working also on this aspect of care, because it's really important.
Thank you very much.
If I can come in there, that was a fantastic answer. I mean, I could see some wry smiles coming up as you said, we have to take egos and financial incentives out of the equation. And that was just, yeah, okay, we've got that. But no, I mean, absolutely impressive what is happening in the Netherlands. And to hear you summarize that so succinctly and so well, it is just brilliant. So thank you so much for that. That was really great. Have you more questions, Gary?
Yes, I do. I'm actually going to go back to you, Helen, because I know you in the green room before this meeting, we're talking about the questions around the ECOS project for Enzo and Jesus. So would you like to ask that question?
I would indeed, yes. So I will address you both, Jesus and Vincenzo, in that you are both absolute powerhouses behind Ensca and also the ECOS project. And you have moved mountains in the time you've both been involved with this work. Looking at the ECOS project, there's a time limitation there. And we see the fantastic work streams that are coming out of that project. So is there a plan to continue driving forward what do you see happening with all this interest and all the work that's being generated within the project when that, when that comes to an end, when the funding comes to an end? We can't just let it stop, can we?
Helen, thank you very much. Thank you for this very nice question and for this great acknowledgement for me, and I think for Jesus. It is the interest, the opinion of MMF and the patients is key, as a key aspect, as I mentioned already. And of course, cost is a very nice program at European level, because for future, and unfortunately, this pandemic also fastened the process. Networking and collaboration are the only way to succeed for this big challenge, and the Netherlands is showing us this. Of course, we are foresee a future. Luckily, Ensca will not end when the cost grant will finish, but we are already working to ensure a future to this project, and it is a daily work, and we have many things still to do. So I think this effort will never end, and I leave the voice to Jesus to say some other things, because Jesus represents what still will be there in future.
Thank you, Vincenzo. Thank you, Helen, and congratulations for the nice meeting and for the invitation. Yes, following the words of Vincenzo, Ensca was created in 2015 with the main objective to promote collaboration. At that time, we didn't have any funding, and we meet together in San Sebastian, in Rome, and in other places, putting just our interest in order to speed up collaborative studies. So the cost action allow us to boost an scaffold on the network and to do a very nice program for 5 years to create the working groups, to involve more people, and to train next generation leaders. But again, once this will expire, we will apply to new grants. We will keep doing multiple things. Due to the pandemic, we learned that we can do many things virtually, so we don't need many fundings for multiple activities, and we will take advantage of that. And we have now ongoing multiple registries, papers, consensus. There are multiple people involved, and this was thanks to many people and many groups that are participating, including the AMMF, the Cholangiocarcinoma Foundation. So we definitely have on board multiple young and senior talent people, very, very much excited about this collaborative international initiative. And we will boost even more in the next year the activities. That's for sure.
That's good. It's very good to know that you've maintained that enthusiasm and from a standing start, it's been truly impressive to see what you have achieved to this point. But I think also, it's indicative of the interest there is in this area, and how people are really anxious to see improvements for cholangiocarcinoma patients. And it's very heartening to see that once there's a vehicle for people to attach themselves to and start moving things forward, it really does start happening. And I think you're both to be hugely congratulated on the work that you've done, which is on top of all your other work and everything else that you do. If I can just ask you, Vincenzo, in your presentation, you mentioned that we had the next meeting in Edinburgh in June, but of course, unfortunately, that has now, because of the ongoing pandemic, that has had to be postponed again. And I've had emails pinging in saying, oh, but shall I start booking my accommodation? I didn't realize it was still on. So can I just say to everybody now that has actually been postponed? And do you know the next date? What will the next date of that be?
it will be, Jesus, can you?
Yeah, it will be most probably July 2022, between 6 and 8. But the information will be provided soon. It will be organized in Edinburgh, again by Luke Bolter and colleagues from the UK, including, of course, AMMF. And we are everybody very excited to meet all together soon in this great venue. But even the next Ensca meeting will be there. We are planning to do a new hybrid meeting, hopefully in Madeira, in Portugal. So this is in prime because we didn't announce yet, but we are doing right now. We had last week a meeting with Rui Castro, the local organizer, and we are trying to do all of our best to go back to the face-to-face meeting, which obviously speed up collaboration, and it's great to see friends and promote activities. No. So this will be hopefully in the first week of September, and we will have a hybrid format. So we will contact everybody soon.
Great. We look forward to that, and let's everybody get vaccinated so we can all get there. Thank you very much.
Thank you.
Thank you everyone for
Thanks,
your wonderful contributions. Over to you, Gary.
So we have time just for one last question, and I'm going to put this question to Dr. Erdmann. It's a question that's just come in from one of our speakers, Dr. Luke Bolter. What should the global priorities be for advancing translational medicine in cholangiocarcinoma?
Oh, that's a really difficult question. I think I see Jesus is already laughing at me because it's a difficult question. I think maybe three points we have to improve. We have to improve diagnostics. So I think we should improve the sensitivity of brushes, of biopsies, and make sure we don't operate people who have benign disease. I think that's for perihilar or distal really important. For the intrahepatic, it's less of a problem. The second point is that I think surgery will remain the mainstay for a long time for treatment of this type of cancer. However, most patients are not suitable for resection because of the extent of the disease. So I think we have, and that's where we have to find more markers that will predict response to therapy, so we can target preoperative therapy more consistently. But another point is we don't have great drugs. You know, we have some chemotherapy, which is somewhat effective, but of course we're looking for a miracle drug. And so I think that's also something we have to work on together. Well, the surgeons can provide, I think the patients can provide all the cooperation, and the surgeons should help the patients to provide the basic researchers with sufficient material to do research with. So that's something I really would like to promote here, is that patients participate in studies. And if your surgeon asks you if we can use your tissue or take some blood samples, please participate, because that will make us smarter. And I really hope that the ongoing trials, like the Keynote trials with immune targeted therapy, are going to give some improvement in treatment regimens.
Thank you.
Does it answer the question?
Yeah, it's a wonderful answer for the session that we've just completed on international aspects. So thank you. We are out of time. We could go on for hours. I'm aware of that. There are multiple questions we haven't answered, so I do apologize. But thank you to our panel on behalf of the AMMF. We appreciate your time and commitment, and we look forward to seeing you next year. Thank you, everyone. Enjoy the rest of your day.
Thank you.
Thank you.
Thank you.
Bye.
Thank you so much. Bye-bye.